Just to let you know, my affiliation is with Alios Biopharma, which is a Janssen pharmaceutical company, which is underneath Johnson & Johnson. So that's my disclosure. Alios was an acquisition in 2014 and really designed to spearhead our early development efforts in infectious diseases. We have discovery, preclinical, and clinical groups working up to phase 2 on our projects, and just want to show what our portfolio looks like at this point. Alios works in this side of the stage, and then as it gets into later development, Janssen will take over on these stages. And you're probably all familiar with our HIV products. Just to mention that we still work on in HIV with Gilead on the single tablet regimen. We work with GSK on rilpivirine, and in particular the long-acting with cabotegravir. I think Janssen, in terms of HCV, still would side with Nancy in that we still are working on the hepatitis C 3-DAA compound, and not on this list is a compound that I'll be working on first in human starting next month, so that's AL611. So we're still very active in hepatitis C. Jordan Feld gave a very nice presentation on hepatitis B. We have a lot of compounds there, primarily those capsid assembly modulator inhibitors, but also therapeutic vaccine, TLR agonists, and the TLR agonist. We're also active in RSV. We have a number of compounds in development there, as well as late development, which is lumicitabine, previously known as AL8176, also known as J&J 1575. Today I'll talk specifically about influenza and our development there. So I think most of you folks here know that flu is not the same as a cold or stomach flu. If you've ever had the flu, you pretty much know it, right? You have high fever, sore throat, headache, muscle pains, cough, and fatigue. I can recall twice in my lifetime having the flu, once as a teenager, and then just 3 years ago I had the flu, and it really does a number on you for sure. But clearly there are complications due to flu, particularly bacterial, viral pneumonia, cardiac and respiratory failure, and really at-risk populations are the very young, of course, who have an immature immune system, the elderly, and of course the immunocompromised, and folks with comorbidities. And there's a real unmet medical need for treatment. I keep pressing the wrong button. So influenza does cause significant morbidity and mortality, approximately 1 billion cases annually worldwide, with 250,000 to 500,000 deaths. It affects about 10 to 20% of the population in the developed countries each season. In the US and specifically, we see about 25 million total cases. About half of them will attend to a medical specialist, and about 2 to 3% end up being hospitalized. And in terms of annual deaths per year, again in the US, it's approximately 56,000 due to influenza. Now we're coming up to almost the 100th year or anniversary of the Spanish influenza pandemic, which occurred in the 1918s. That pandemic killed 50 million people. So clearly, medicine has gotten better in those 100 years, but folks do believe we're due for another pandemic. Hopefully, we can have treatments to both prevent and treat that from happening. So what is influenza? It's an orthomyxovirus. There are actually 4 types of this virus, types A, B, C, and D. Type D only affects animals, so really the ones that affect humans is type A, B, and C. Type B and C cause a milder disease, and in fact type C is so mild that it's not really considered a clinically relevant infection. But we do worry about type B, and in particular we also worry about type A, because that one is the one that's involved in pandemics. Now, what I have here is a cartoon of what the virus looks like. It's a negative strand RNA virus. It's single-stranded RNA, which codes for at least 10 known proteins. As you can see here, it's an encapsulated protein, and then there's a lipid envelope. And then it has particular proteins expressed on the outside, hemagglutinin and neuraminidase. And this is just a scanning electron microscopy of the virus. Even though the cartoon here shows it's spherical, it's really more ovoid or blobby virus. So influenza A is characterized by the subtypes of those hemagglutinin and neuraminidase. So hemagglutinin is what binds to the epithelial cells, so it binds specifically to sialic acid. And the neuraminidase is also known as sialidase. It actually helps with the cleavage of the sialic acid, so it's involved in the release of the virus. Once it infects. Now, there's various subtypes of the hemagglutinin, ranging from H1 to H17, all of which can be found in the bird, only some of which have been known to affect humans. And similarly for neuraminidase, there's 9 known subtypes, again, all found in the bird, only some of which affect humans. And you can see that there's also other animals that the virus can infect. So transmission, well, first of all, I'll talk a little bit about the nomenclature. So sometimes when you read the literature, typically what they'll say is something like this. The A stands for influenza A. This is the subtype of the hemagglutinin and the neuraminidase involved. And in this particular case, if you're talking about the pandemic swine flu from 2009, you'll see the abbreviation PDM for pandemic, and then the year 2009. So when you read the literature, that tells you what viral strain they're talking about. Now, in particular for type B virus, it doesn't mutate as much as type A does. And there you don't really talk about the H1N1, the H and the N subtypes. You really talk about lineages. So there's really 2 lineages to be concerned about, which is B Yamagata and B Victoria. Now, I mentioned that the virus can change. So the polymerase involved in influenza roughly makes errors 1 in 10,000 nucleic acids. And what happens is you can have a point mutation that could lead to what we call an antigenic drift in either the either in the hemagglutinin or the neuraminidase, and that typically causes the seasonal flu. So it's a change enough in the virus that your immune system may not recognize it, or that the vaccine that you were given may not be as effective. Now, what might happen in some cases is you can get major reassortment. So in the animals in particular, when they're infected, they could be infected with multiple viruses, and a major reassortment may occur there, and then you might come out with a virus that hasn't been seen before. And so, for example, I mentioned the pandemic that may come up. One can never know, but at least the experts think that H7N9 is probably the most likely to start the next the next pandemic. This is a virus that's been circulating primarily in China between humans and birds. We've never really been exposed to this before, and at this point it has a 30% mortality rate. So the animal reservoir is very important, I think, for influenza. As we know, it circulates among birds, including the duck and the chickens. It circulates among pigs. You could find it in seals. You could find it in cats, actually, as well as horses. And of course, humans are mostly exposed through either through the birds or close association with the pigs. So it's usually caught first by the veterinarians who see that there's influenza circulating within those animal species. And sometimes those farmers will actually have to cull their birds or their pigs to prevent the jump to humans. So one of the challenges of influenza is that it's a seasonal disease, and what we mean by that is that it really occurs in the northern hemisphere, at least between the months of October and March. So this is from the CDC surveillance. It's the latest data showing this line here is January 1st, so this is from October 2016 to February 2017. This is the percent of viral visits for influenza-like illness. So you can see, and this is the baseline. So the baseline is a little over 2% of hospitalizations, and you can see that during the month of early January, there was a spike in terms of influenza hospitalizations. Now that's good if you're doing drug development in hospitalized subjects, not so good, of course, from a global public health perspective. And just as another point here is this is the 2009 swine flu pandemic that I pointed out that peaked very early in October and then caused a significant amount of hospitalizations. Now there's other years where it just percolates very low, such as I think this is 2010, 2011, which was right after the pandemic. Maybe a lot of people got vaccinated, I'm not sure, but it was a very low incidence. So you can see that if you're doing a study in hospitalized subjects, it really depends on the season, how good the how good the vaccine protects patients, and sometimes one can't really predict how well you do. Now, so usually during the winter months, again, close proximity to folks is how you transmit the virus. Coughing and sneezing, of course, aerosolizes the virus. The virus can actually survive in colder temperatures, so that may contribute to why you see it more in the winter months than elsewhere. And just as an aside, and I don't want to get too political, but global warming, people do have these science fiction, whether it's science fiction or not, they do say that the virus can survive in like the tundras of Siberia, where the birds migrate over, and if you get the ice melting, it can actually release the virus, potentially showing up some of these unusual influenza strains, including the pandemic strain that's possible. So there are, in terms of treatments and prophylaxis, they are available, but they have limitations. So vaccines are administered. They're anywhere from 70 to 90% effective. The previous, last season, it was only about 40 to 50% effective, actually. And of course, in elderly patients or those in the nursing home, the effectiveness drops. It takes a significant amount of time to develop these vaccines, and the body develops them in about 2 weeks after vaccination. So you really should get vaccinated sometime in the area of September to prepare yourself for October. And of course, it's manufactured through eggs, and in terms of manufacturing, it's very, the chickens, if they're infected with influenza, there goes your eggs for the vaccine administration. So it can be a limitation. In terms of the antivirals, there's really only one class of drugs called the neuraminidase inhibitors. You might be familiar with the oseltamivir, zanamivir, peramivir, for example. There is some baseline mutations that circulate for those can be as high as 10%. They really need to administer within 48 hours of being symptomatic, and that's one of the challenges, again, of influenza development, is you really have to dose within the time frame. So this is just a life cycle of the influenza. There's entry in the virus, it fuses, and then it releases the genetic component. Then there's a replication of the RNA, and then eventually the virus is released. And as I mentioned, this is where the neuraminidase inhibitors work at this cleavage of the virus as it's coming out of the infected cells. What we're working on, at least at Janssen, is inhibition of viral replication, or the polymerase. Excuse me. So the polymerase consists of three proteins, PB1, PB2, and PA. So two basic proteins and an acidic protein. Pimodavir, which was J&J 3872, was acquisition from Vertex. It's also known as VX787. This is a PB2 inhibitor. It's only effective against influenza A, whereas AL794, which I presented the first in human data on Wednesday, that's a PA inhibitor, and that inhibits both type A and type B inhibition. In our early development efforts, we do have a multi-domain influenza antibody that we're working on. It's still very early, so I won't talk a bit too much here on that one. I mentioned to study influenza compounds, one of the things we do is to assess its antiviral activity, and we can actually do this in human influenza challenge study. So here we actually take healthy volunteers and we expose them to influenza. We've done this before for RSV, for example. We can also do it for dengue. Not that I'd probably enroll in that, but it's not considered an efficacy trial, but it helps determine the antiviral activity or prophylaxis of the drug. So unfortunately, there's only a limited number of clinical sites that can actually do these types of studies. You have to have a GMP manufactured influenza, and there's a real question about how reproducible these challenge studies are. And because we use an attenuated strain, there are some limitations to extrapolating to real-world infections. So even though we infect them with a strain of virus because they're healthy, not all the time does that infection take, and it's approximately 50%, at least in our experience. And then if you're looking at reduction in symptoms as part of your assessment, because it's an attenuated strain, they have less symptoms. And it's done under a very controlled environment where you know when they get the symptoms and then you can administer the drug, which is obviously not the same in the real life. I showed this on Wednesday just as a reminder, for AL794, which is our endonuclease inhibitor. This is black is the viral load for placebo, and then with 50 milligrams and 150 milligrams, we were able to show a decline in that viral load comparably. Now, I did mention the reproducibility of these viral loads in the challenge studies can be questionable because, for example, in the 50 milligram BID, that was actually a separate cohort getting dosed separately from the 150 milligram BID, and you can see that there's a difference, at least in the baseline starting point for the viral load. So, and we've seen this also with RSV as well. When one does drug development, hopefully you could get into the phase 2 and phase 3 trials, at least when you look at the indications for treatment. They could either be prophylaxis or treatment. Those are considered different indications. Also, different indications are uncomplicated versus complicated. We're focusing primarily on complicated influenza, and these are trials primarily in the high risk or with underlying disease, obese or in the immunocompromised. So the patients are much more difficult to begin with to do studies there. And so far, no study has demonstrated efficacy in the hospitalized patients. So from a regulatory pathway, it's a bit unclear how we develop drugs there. And at least at Janssen, we've decided to do community study or uncomplicated studies, get some experience before jumping into the hospitalized patients. But there are different, at least there is a guidance by the FDA in terms of what one can do. You can have an add-on superiority trial, which is taking your investigational drug plus standard of care versus standard of care, but here standard of care is actually off-label use. Or you could do a blind, double-blind randomized dose and duration response trial. Oh, yeah, sorry. Okay, so I just want to really show our Topaz study, which is pimodivir. We just presented this at the iServe meeting on Wednesday, so I'm pleased to be able to show this really quickly. Pimodivir was given 300 milligrams, 600 milligrams, pimodivir 600 milligrams with oseltamivir 75 milligrams, and placebo. We were able to show a significant viral load decline in influenza over time. And that resulted in terms of a change in AUC viral load with pimodivir 600 milligrams BID. We saw a 4.5 drop in the AUC viral load, and in combination with oseltamivir was minus 8.6, so significant activity in the uncomplicated patient population. Safety-wise, there was nothing really to mention other than diarrhea was the most common treatment adverse effect. So just to summarize, I think the challenges in influenza has been primarily in terms of the complicated influenza. It's an unmet medical need. I believe we need combination therapy with new mechanisms of action. Seasonal and acute. It's a seasonal and self-acute limiting disease. There are challenges in enrollment, and then clinical endpoints. I didn't really get a chance to speak too much, but it's not like HIV or HCV where you can look at viral load decline. We really look at symptom and outcome-driven responses, and no surrogate markers are known. Thank you. Sorry to go over.